so much everybody who's attended this morning so far. We've got a group of MPs and journalists joining us, and also members of the public. So thank you so much everybody for tuning in to listen to what EveryDoctor have got to tell you this morning. We are extremely concerned at the moment about the NHS, and we wanted to present it in a way which explained every different element which is contributing to the winter crisis happening. We're also going to briefly explain what the history of the NHS winter crises is. It's a term which has been used in recent years, and we wanted to give some sort of parameters to discuss it with. We're very worried. It's the beginning of December now, and we're coming into the winter months. This is obviously the busiest period of time for the NHS. So, Hannah, could you move on to the next slide? I'll explain how the presentation is going to work. So first of all, I'm going to give a short presentation explaining what's currently happening, the latest NHS figures which came out yesterday, and our greatest concerns as doctors and the concerns of those within our network. We're then going to hear from Emily, who's a GP, a senior GP up in Liverpool, and Emily is experiencing a huge amount of pressure at the moment. She's going to illustrate to us how that feels on the NHS front line. At 12:30, we're going to have a question and answer session where myself and Emily will try to answer the questions of the people joining us today, and then we'll wrap up hopefully at about 1:45. I'm just going to say at this point, members of the public who aren't actually in the Zoom meeting won't be able to ask questions, but if you pop them into the bit underneath the Facebook live stream or on Twitter, members of our team will collate them, and we can reply to you if you give us an email address. You might have pertinent questions that you'd like us to answer, and we're very happy to. Okay, thank you very much, guys. Just a little bit of housekeeping. If you do have questions, please pop them into the chat box in the Zoom meeting, and we all stay on mute unless we're speaking. Okay, could I have the next slide, please, Hannah? Okay, so we're describing what's happening in the NHS at the moment as the domino effect. There's lots of elements to the NHS service, and there's also some external factors which place pressure on the service as well. And each of those things adds, contributes to how well the service will run as a whole. Now, there's been lots of failures recently in the service for lots of different reasons. Some have been building up for years, and some are as a result of COVID. But we're now in a position where the pressure on the NHS simply cannot be sustained and patients are at risk. So we wanted to explain the 7 different cumulative, 7 different areas creating a cumulative crisis on the NHS. Could we have the next slide, please, Hannah? Okay, so I'm just going to briefly talk about the history of NHS winter crises. It's certainly a term that I've been very familiar with over the last, I would say, 5 or 6 years since I started campaigning, but we looked into the history of it. So what we have found is an article by Full Fact from 2017. This is a crude search of articles containing both NHS and winter crisis in the newspaper database since 1993, shows that the term was quite common in newspapers in the UK in the first 5 or 6 years of the Labour government, 1997 to 2002. There was a big spike in the year 2000 when there was a big flu outbreak. Winter crisis was heard of very little after 2002 until it re-emerged as a common talking point under the coalition and then Conservative governments from 2013 onwards. As a doctor, certainly my experience when I was working in the NHS is that there would be a period of the year where things became much more fraught, and beds were often few and far between. Everybody felt more stretched, and there were often staffing problems. But we now rely on our network to tell us what's happening and these statistics. So could you move on to the next slide, Hannah? Okay, so we've set this situation out as a series of dominoes, and we'll explain each of them in detail after I've just set out this slide. So the first is hospital bed pressures. The second is COVID. The third is pressures upon NHS primary care at the moment. The fourth is ambulance pressures. The fifth is NHS A&E waiting times. The sixth is general hospital pressures. And the seventh is social care, which isn't strictly NHS based, but social care has a big impact on the NHS and how the NHS functions. And so we've included it during this presentation. Could you move on to the next slide, Hannah? Okay, fantastic. So I'm going to start by talking about hospital bed pressures. I'm just getting up the the information in front of me because it's very small on my screen here. Okay, fantastic. So we're all familiar with the idea that hospitals are under pressure. And one of the parameters we use to assess how busy and stretched a hospital is what proportion of the beds are occupied at any one time, because that tells us if a surge of patients came into the hospital needing treatment, how likely it would be that they would have a bed quickly and efficiently in order to care for them. The measurement within the NHS is taken at midnight each day. For hospitals to work effectively, you have to have a degree of give in the system. That means you need the percentage of bed occupancy to be low enough that if we suddenly have an increase in illness burden in the community, let's say during the winter months when there's more respiratory illnesses, if a lot of patients turn up at a hospital, the doctors and nurses and other staff can therefore fill up those beds with the patients who need them. If you're running at a very high bed occupancy, as we have been recently, that is very, very challenging. If you suddenly have a lot of people needing a bed all at once because there's an illness spreading in the community, you're going to find that extremely difficult as a hospital, and that puts patients at risk. So I'm just going to explain a little bit about how these parameters work. NHS hospitals are commonly told to aim for a bed occupancy rate of about 85%. That 15% on top of it gives the hospital enough give so that they know they can serve their community well at times of high pressure. The closer the percentage gets to 100%, the less ability a hospital has to absorb the additional pressure. However, and this is the current situation, the total percentage of occupied beds and the percentage of occupied general and acute beds, that's people who've got general medical conditions for which they require hospital treatment, has not been below that safe level of 85% for the past 10 years during the winter months. So that means that over the last 10 years in the NHS, we haven't kept things safe a single time over the last 10 years, which is awful. Since Q4 2014 to 2015, that's the end of the year, so that'd be winter 2014-15, the percentage of occupied general and acute beds has continually been above 90%, apart from one drop in one quarter at the end of last year. So it's showing that things are getting more and more stretched during the winter months in terms of bed pressures. Why is the NHS hospital bed occupancy so high? Well, it's partly because the number of NHS hospital beds have halved over the last 30 years, from the end of the 80s to now. The number of hospital beds for those general and acute admissions have dropped by 44% since the end of the 80s. And the largest percentage falls have been in people who have mental health problems or people who have a learning disability who need to have a hospital bed. Those proportions, the mental health bed capacity has fallen by 73%, and learning disability beds have fallen by 97% since the end of the 80s. Now, some of this happened at the end of the 80s as a result of a policy shift where more people were being provided with community care than inpatient care. And it's a complex situation. It's not all bad. Community care has a lot to offer for patients who have long-term conditions. However, we don't have enough bed capacity for those who do need hospital treatment, and it is really affecting services. Another group which has fallen enormously in percentage of beds available is maternity beds. Since the end of the 80s, we have a 52% drop in bed capacity in the NHS. And that's mostly a change in how long mothers stay in hospital after giving birth. Could we have the next slide, please, Hannah? Okay, I'm just going to tell you one last thing before I move on to this slide in front of you, actually. We wanted to provide a bit of a comparison of what the bed provision in the NHS was like compared to other countries. And I've got a chart in front of me. If anyone would like access to the chart, because it's quite telling, send us an email on campaigns@everydoctor.org.uk and we'd be very happy to send over our presentation. But basically, it's a chart that compares the UK to lots of countries around the world who we would expect to have a similar health system. And of all of the European countries on this chart, along with the USA, Canada, and New Zealand, our bed numbers are the lowest in terms of proportion of beds to number of people in our communities. Okay, I'm coming on to domino 2. So COVID. Now, COVID has obviously had an enormous impact on our health services for almost 2 years now. And yet there were huge problems beforehand. And so we want to put them into context. COVID has placed enormous pressure on the NHS in each area of the service, both community and inpatient, and also has impacted on NHS staff sickness, obviously, because staff are in contact with patients every day and haven't been able to self-isolate in the way that some members of the community have been able to. Horrifyingly, many frontline staff have died of COVID and weren't protected properly. We also can't minimise the impact of the vaccine programme on the NHS in terms of staffing. In England, many GPs set up the initial vaccine centres, and many continue to run vaccine hubs and also booster hubs now. We've just set out some statistics here, just showing the direct impact of COVID on services in England alone. And it's important to recognise that obviously England is only one part of the NHS. So it says total beds occupied by COVID patients to date, from the beginning of the pandemic until the 1st of December. So it's 123,510. Total beds occupied by COVID patients on the 1st of December 2021 was 5,829. And COVID-related absence of NHS staff through sickness or self-isolation is 15,826. So that's quite a proportion of staff. And every staff member who's absent at the moment has an impact on patient care. We simply don't have the staff to lose. As you all know, COVID is a huge problem at the moment in the UK, particularly with the new variant Omicron, and we are concerned about what is to happen over the next few months. I very much doubt that the pressures on the NHS from COVID are going to be reduced. On the 8th of December, we had 51,342 new people who had a confirmed positive test. Between the 2nd of December and the 8th of December, 339,861 tested positive, and that was an 11.3% increase on the previous 7 days. I know that we're throwing a lot of statistics at you at the moment, but essentially things are getting worse. COVID cases are rising. We have a new variant. We haven't got a full understanding yet of how this new variant is transmitted. Maybe that it's more transmissible than previous variants, and scientists and doctors are very concerned about that. I'm just going to say this really clearly. I'm sure that the people on the call agree with me on this. We believe that the government needs to take firmer action against COVID at the moment. More steps need to be taken to mitigate the spread of this virus. It's really unsafe at the moment. We're very concerned. Okay, let's move on to domino 3. Primary care. Okay, so primary care is all of the services in the community that GPs run. There's been a lot in the media recently, I'm sure you've seen, about whether GPs are seeing their patients face to face, and a lot of criticism, and a lot which has been completely undue, to be honest. We've run a previous briefing on this. So if you would like to have a copy of the entire briefing, please send us an email. Again, that's at campaigns@everydoctor.org.uk, because we don't have time to run through all of the information now. But essentially, we just want to set out exactly why GPs are so busy and why some patients are struggling to access care at the time that they would like to at the moment. Primary care is under extreme pressure at the moment. I run a doctors community. I speak to hundreds of doctors a week. We talk in our network to probably about 25,000 doctors. I don't know of a single GP surgery that has closed during this pandemic. They've been open and they've been seeing patients, and they've put themselves at risk a great deal, actually. But the raw numbers speak for themselves, quite frankly. There were 966,406 more GP appointments in England in the second week of November compared to the same time last year. That's almost 1 million more appointments in a single week recently. There are, at the same time, fewer full-time equivalent GPs now than there were in 2015. We've had several health secretaries now make pledges to increase the numbers of GPs, but that hasn't been achieved. We have fewer. And each of the GP practices we do have has an average of 1,849 more patients than in 2015. So that there's less GPs, they're busier, and the healthcare demand now is huge. And a lot of that is because people didn't have appointments during the first and second wave of COVID because the system was totally overwhelmed for other reasons. So the current situation is that we now have 0.45 fully qualified GPs per 1,000 patients. That is not very many. If you have a little look at the chart on the right-hand side here, it's not a direct comparison to what I've just said because we're struggling, to be honest, to find up-to-date information on this. But what we have managed to find is an estimation of the number of general practitioners per 100,000 inhabitants in EU countries in 2018. That's the most recent figures we've been able to find. But if you have a look here, I don't know if actually we're on here. We will find out that figure. If anyone would like to know the exact figure, send us an email because the UK isn't on here. But I've got a feeling the UK comes pretty low down on this list of how many doctors you have per patient. Okay, could you go on to the next slide, please, Hannah? Okay, domino number 4, ambulances. Ambulances is a huge, huge concern. And actually, I don't think this is getting sufficient media attention at the moment. There are lots of horrifying stories that we're hearing in our network. And actually, we've been trying to approach journalists about this to raise the alarm. And the sense that we have is that people have got so used to things being under pressure and things not working very well because of that pressure, that patients perhaps are absorbing these weights. They're not complaining. Healthcare staff have become used to it. And we're not raising the alarm sufficiently about these. It's really awful. We're hearing on our network things like elderly people lying on the floor for more than 12 hours, people with life-threatening illnesses not being picked up by ambulances. We've heard from paramedics. This is horrifying that they are turning up at people's homes and finding that patients have died in the intervening period between calling an ambulance and an ambulance arriving because the ambulance service is simply under too much pressure. I've got absolutely no criticism for the ambulance service or paramedics. They're working flat out. But what's happening, and I'll explain that and then I'll explain what it actually says on this slide, is that when an ambulance is called, they have to go to the most urgent patient in the queue. And once they've picked a patient up, they take that patient to hospital. But if an A&E is full, if there's nowhere to put the patient, and if an ambulance cannot hand over that patient to the staff within the hospital, they stay with the patient until they can do so. And so the situation we have is car parks full of ambulances waiting to offload patients and hand them over into the safe care of staff. And meanwhile, people in the community waiting for an ambulance are not getting picked up in time. So it creates a backlog. Now, the way that ambulance waiting times are measured in the NHS is, as it says here, in 2017, NHS England implemented new ambulance standards across the country to make sure that everything was being done in an efficient manner and so that we could measure how things were going. So there's 4 different categories, C1, C2, C3 and C4, and they're categorised in terms of how urgent the ambulance is. So C1 is a life-threatening injury and illness, and a patient should have an ambulance arrive within 7 minutes, and it kind of goes down from there. So when you get to C4, it's a less urgent ambulance and it should be responded to 90% of cases within 3 hours. So that's how it works. And we've got the statistics of you know, how well this is going. In October 2021, the ambulance services of England answered more 999 calls and more calls in total per day than any other month since the records began. For all categories, C1 to C4, the response times in October 2021 were the longest since the measures began. The data for November shows a shorter average response time than October, so things have slightly improved, but they still remain longer than in all previous months for which England data is available. And just to give you a measure of how many calls that is, in October 2021 per day, there were 32.7 thousand calls to 999 answered, which was 3.5% more than the previous month. It's really terrifying, and the government need to take responsibility about this because it's not going away and we're getting into the colder months of the year. So we're very, very worried. Hannah, could you move on to the next slide, please? Okay, so we're going to talk about A&E waiting times now. So again, we have measures of how efficient an A&E department is working. So NHS A&E departments are extremely busy at the moment. The total number of attendances in November 2021, so this is the statistics that came out yesterday, showed that there were 2,040,000 people attending an A&E. That was an increase of 37.4% since last year. That's enormous. For many years now, we've assessed the pressures upon and the performance of A&E departments via several metrics. These include the raw attendance numbers and the proportion of patients who are seen and discharged within 4 hours, and also something called the 12-hour DTA breach. Now, the 12-hour one is once a doctor has seen a patient and there has been a decision to admit the patient to hospital, a 12-hour breach means that that patient has waited longer than 12 hours, normally in a trolley or on a bed, before they get transferred to a ward. And we want to absolutely minimise that because it's not good for the patient, it's not good for their care, it's not dignified. Quite often they're sitting in a non-clinical area, but also it's bad because it disrupts the flow of patients through an A&E department, and it's going to impact ambulances dropping off patients and enabling their care to happen quickly. So what you want in an A&E department is a really efficient flow of patients through to the department so that everybody is seeing healthcare staff as efficiently and quickly as they possibly can. Okay, so clinicians work extremely hard in A&E departments to minimise the waiting targets. And actually, when you work in an A&E as a doctor, you'll have a screen in front of you telling you every single patient in the department, and there will be a clock next to them with a system that tells you how long that patient has been in the department for. And it flags to the clinicians because it's extremely important that that's on your mind, so you know that you're seeing your patients efficiently and you're delivering the best care that you can. The A&E doctors that I'm speaking to, just to sort of divert very briefly, are having a really heartbreaking time at the moment. A lot of people are turning up at work feeling like they can't deliver the care they would like to because things are so overwhelmed, seeing heartbreaking situations of often elderly, often vulnerable people receiving care not in a very dignified manner in non-clinical areas, in corridors. And that's not what NHS staff want to be doing. So I'm just going to tell you a little bit about how A&E is actually matching up with these metrics at the moment. So these are 3 statistics. In November 2021, only 61.89% of patients were seen within that 4-hour deadline. This is the lowest performance since this collection began, and that began in 2004. So in 18 years, they're performing the worst. And that's not for want of trying. There were 121,000 4-hour delays from the decision to admit to admission this month. That compares to 71,000 in November 2020. So that's a significant deterioration since last year. And of those people, 10,646 were delayed over 12 hours. So they're the people that I was telling you, we've decided they needed to be admitted to hospital and they're then waiting over 12 hours to go onto a ward. It's not what any of us would want for our loved ones. And all of these are the highest numbers since the collections began. Okay, could we go on to the next slide, please, Hannah? So domino 6, we're 6 out of 7 now. I think you probably will have seen this actually because this did make the news yesterday. Aside from the bed pressures and the A&E waits, another factor that impacts on NHS hospitals is the waiting lists of patients who are waiting to have outpatient clinic appointments, or perhaps they're waiting for elective surgery. And at the end of October 2021, so that was the end of last month, the last month's data, there was a backlog of 6 million people waiting for NHS hospital treatment in England alone. And that's not counting Northern Ireland, Wales and Scotland. the pressure on the NHS hospitals is multifactorial because you have the same staff teams running the clinics as the wards, and the pressure's coming from all angles. So let's imagine that I'm a respiratory doctor. I would have a ward of patients, respiratory patients, and I'll be looking after them. I'd also do several clinics a week and go down to the area of the hospital, which is the outpatient clinic. Now, if you're struggling up on the ward because of problems with bed pressures and problems with A&E flow not working very well and concerns about discharging your patients back into the community, and then you go down into the clinic and your clinic is overwhelmed because of absolutely enormous waiting lists, you can imagine how stretched those staff feel. It's awful. It's unsustainable. So in October 2021, The Guardian reported that the NHS in England has 94,000 staff vacancies. The vacancies are a massive problem. We're not really going to focus on that today, but please just consider how this situation feels for NHS staff, because it's absolutely appalling. It's appalling for patients and it's appalling for staff. Since 2010, also, we cannot ignore the fact that there have been huge funding cuts. The government have made over 40 billion in departmental cuts. That's had a huge impact on the NHS. Other measures have actively deterred staff from staying in their jobs or from joining the NHS. The student nurse bursary has been removed. There have been successive pay freezes, which have meant that senior doctors, for example, have had pay cuts of almost 30% in real terms since 2010. There's locum caps, which means that if you're trying to find extra staff to do extra shifts on their days off, there's caps on the amount that a hospital can pay them, which mean that staff aren't really going to be incentivized to come in when they're already exhausted. And there's also very restrictive pension taxation rules. And the way that happens is that the most experienced staff members, those professors and consultants and those who are running places with extreme expertise for everything they've been through over the last 20, 30 years, are being restricted from working extra hours because they're being taxed extremely highly, in some places over 100% taxation on the work that they do, in addition to their normal hours. All of this is causing staff to leave. So we've got an absolute pressure, a pressure boil situation. It's not sustainable. For a few years now, I myself have been warning of this, have been trying to raise the alarm. Many other doctors and other healthcare staff and healthcare leaders have been doing the same. We knew things were getting bad. COVID itself was unprecedented almost 2 years ago, but it certainly wasn't unprecedented this winter. This could have been planned for. Our patients are being failed. Our staff are being failed. I'm very, very concerned. People are dying because they're not receiving adequate care. And that's simply wrong. That's not what the NHS is set up for. Could you go on to the next slide, please, Hannah? We're going to talk very briefly about social care. Social care isn't my area of expertise, but it is very relevant here. So healthcare doesn't exist in isolation. Social care also impacts the NHS. Care homes in England are facing the biggest staff shortage they've ever had on record. They've got 105 positions unfilled. That also is just the most enormous staffing gap, and I can't understand why it hasn't been addressed. Most recent data from February 2020 showed that an average of 5,370 people's discharge from an NHS hospital bed was delayed every day. Now, there's a problem with these statistics. We've been trying to dig in and find more recent statistics because that's before COVID, and quite honestly, things have probably changed. However, we haven't been able to research it. NHS England suspended data collection and publication for 2020-2021, including the delayed transfers of care, which are the patients who sometimes get referred to as bed blockers, which we don't like that term at all. It means that the most recent data that's publicly available is from February 2020. We probably need to find out what that data has been over the last almost 2 years, because I'm sure it hasn't been very good. Okay, could you move on to the next slide, please, Hannah? I worry sometimes in these public presentations that my language is heightened and that I perhaps sound like I'm overplaying something or overstating something, and that there's a particular capacity people have for these sort of stressed out calls you might have from doctors and nurses. And I'm also very aware that for many years now, because staff have been talking about an NHS crisis, it might not, it might seem a little bit like the boy who cried wolf every single winter. We're all talking about the same thing every winter. But quite honestly, the reason we're doing that is because when you train as a member of healthcare staff in the NHS, you feel deeply about delivering a good level of service to your patients. And when that isn't possible, there's a moral injury that occurs. It's very, very difficult to rid yourself of the idea that you're not doing enough and that your patients are failing. And we have statistics now to show that patients are dying because of the cuts in funding and the lack of staff in the NHS. I cannot stress strongly enough how alarming this situation is, and I don't think it's receiving enough attention. And I think you can see that simply by looking at how many people have attended this meeting today. MPs across the political spectrum should be terrified about this, should be setting aside political differences, and should be putting their constituents first. Because quite frankly, it could be any of our loved ones lying on the floor waiting for an ambulance. It could be any of our loved ones in an A&E department dying because they don't receive the care they need. And it could be any of our loved ones branded as a bed blocker and unable to access social care. And I don't think I can say more than that. The NHS is crumbling before our eyes. The realities on the front line are terrifying. We're deeply concerned for NHS staff and patients. We run a large network of doctors. They're at the end of their tether. The ones I do hear from are having the worst moment of their careers. There's many I don't hear from anymore because I suspect they've turned inwards and they're just trying to get through the days. But it's awful. It's truly awful, and it can't continue. Okay, I'm going to hand over now to Emily. Emily is working on the front line as a senior GP. And Emily is someone who throughout the pandemic has advocated very strongly for her patients because she's very concerned, alarmed. I mean, insert, descriptor there. But Emily, do you want to tell us what's happening where you are at the moment?
Yeah, absolutely. So I work in general practice, as you can probably tell from the lovely ensemble behind me. We are and have been for some time in sort of quite a disastrous state, I think. I'm now seeing increasing numbers of colleagues going off sick with burnout and stress, which of course then the knock-on effect is that the people who are left are struggling even more. I think we've been warning for months that the NHS is on the precipice of disaster, and actually now we've got about half our foot over the edge into clear space. The problem, I think, absolutely, Julia has explained perfectly what the problem is. And I think, I see this all day, every day with a number of patients who are scared, who are angry, who are just bereft, knowing they just don't know what to do with the situation. And I think quite interestingly, we've had 3 members of staff resign recently, and they have all cited the reason that they are resigning is because the amount of abuse that they're taking from patients. And that isn't born because patients are just horrible people. They aren't. It's born out of frustration, and that frustration stems from a lack of clear central messaging. So I think Julia's right. We've discussed what the background to this is, and people have to take responsibility for the fact that those decisions have happened on their watch, and that is where we are now. But what we have to do is look at what we can do moving forward to try and make this work as best we possibly can, and to try and minimise the damage, because I think that's where we're into now. We're now into mitigation. This is not fixable overnight. This is now mitigation. And for me, the big problem is the lack of clear central messaging. So My patients are quite surprised when sometimes I'm ringing them at like 9 o'clock at night, because that is the first chance I've got to actually get round to speaking to them, because I've been firefighting any number of emergencies in the meantime. And they all say, well, you know, what are you doing still working? Well, you know, there are patients who still need to be sorted out, and I will be still working for many hours. You know, I don't expect to leave before midnight quite often. And they're surprised by this. And the reason they're surprised by this is because they still think that we are doing 2 sessions and having a round of golf at lunchtime. And that is partly because of the narrative that has been allowed to be circulated in the mail. I'm not blaming the mirror. In the media, without any kind of comeback or support from people who should know better in NHS England and the Department of Health and in the halls of government. And in particular, you know, I would just like to point out at this point that the Secretary of State for Health and the head of NHS England, which I would remind you is supposed to be an apolitical organisation, actually both backed the Daily Mirror campaign, which is, in my humble opinion, grounds for sacking instantly. But there we go. And the lack of clear messaging centrally means that people don't understand that actually in general practice, we're trying to do the day job. I'm still trying to see my mums of newborn babies who are terrified about all the usual things. And this is what I should be doing. This is what general medical services are. That's what I'm commissioned to provide. However, I'm also dealing with massive numbers of worried well, people who've been waiting a year for a hospital appointment, people who have been discharged from hospitals probably earlier than they should have been, still in poor states of health, still needing lots and lots of input, lots and lots of letters coming out from secondary care. Dear doctor, can you just do, and then a list of things. And the answer is no, I can't, because I haven't got the resources to do it. The pressure basically comes down, and unfortunately in general practice, there is nowhere for us to pass that pressure on, which is why we are in such a parlous state. A&E is falling apart, and we have a knock-on effect on A&E, and A&E have a knock-on effect on us. So, you know, the problem is that we then get into this blame game where people are turning against each other. And the problem is, as I say, a lack of clear messaging. So people need to know what their reasonable expectation should be and what is unreasonable. And actually, in line with the October NHS England release, what will be done about their persistent, unrealistic demands and the way that they make them. What can they expect and how should they go about accessing things? So if their appointment is over a year that they've been waiting for the hospital, don't come and ask me about it because I haven't got a clue and I can't do anything about it. We're getting increasing numbers of, oh, the hospital told me to get an expedite letter from you. I can't do that. I haven't got time to do that. Honesty about how long it will take the NHS to recover, because I think that is a big thing, because I think people think, oh, it's business as usual. You know, we had Freedom Day, the NHS is fixed again. This is going to take years just to get through the backlog of outpatient appointments. And until the backlog of outpatient appointments is dealt with, the pressure on general practice will remain extraordinarily high, because that's where everything gets sent to. If it's not being dealt with in hospital, and please remember, we've referred them to secondary care because it's beyond our scope, we're not specialists, but that's where it flows down to. So we're left trying to keep people going for that interim period. So that will take years as well. So people can't expect to have a doctor's appointment for their verrucas. They can't expect to have a wee bit of a chat about X, Y, and Z while it's in this state. And people need to be very clear about how long this is going to take and how long they're going to have to manage their expectations for. And ultimately, this isn't about money. You can chuck as much money at it as you like. If there aren't the people there to actually bring in, it does nothing. It does nothing. We need staff, we need beds, we need people to be told the truth so that they can actually make wise decisions about the ask of healthcare. And we need backing that when we get the abuse because of things that are out with our control, somebody will step in and do something about it, because at the moment you phone the police and nobody's interested. So nobody feels safe at work. They're getting abused by patients. And it just means everybody is miserable and everybody's heads go down and their resilience is already at zero. and then they go off sick. So this is the situation we're in. And I think it's very, very clear for me and for my practice that actually good quality central messaging that is honest about the state of things, is honest about what is realistically expectable, if that's a word, from the NHS, and is honest about the length of time this is going to go on for, is the only way we are possibly going to survive the next 6 months, 3 months, possibly winter pressures, who knows. But I think Julie's absolutely right. This is really pressing, it's really dire, and if we don't act now, it's too late.
Thank you so much, Emily, for joining us and explaining that. It's really, really helpful. Hannah, could you go on to the next? Yeah, so this is a really difficult slide to write, quite honestly. I sat down the other day when I was writing the briefing notes, and I think when you've been saying the same thing in the media for 5 or 6 years, I mean, honestly, our team and other teams going to the press and saying it's a winter crisis, something needs to change both short and long term. There needs to be funding now to get the staff, there needs to be long-term funding to train things, to get the service running, to get the infrastructure better. And you get ignored 5 or 6 years in a row, and then it turns into a situation where it's literally crumbling in front of your eyes, and you're trying to consider, what can I tell politicians needs to happen now? It's really hard because, like Emily says, you don't create a brilliant healthcare system overnight. It's impossible. And because every area is failing, you can't just stick a massive pot of funding in one place and fix it all. There are a couple of things that could be done to improve things in the short term. So first of all, the government needs to meet with healthcare leaders and actually listen to them. There's lots of healthcare leaders. I don't actually consider us to fall into that category. We're campaigners, but there are trade unions, there are royal colleges, there are other people who are collecting this data, and this needs to be a situation where experts are listened to. There's an awful lot of expertise within healthcare, and there are a lot of people who work in policy who could suggest ways that things can improve to maximise efficiency in the NHS in the coming months. Lots of suggestions have gone unnoticed and ignored actually during COVID. The second thing is we need to look very carefully at how many staff we have in the country who would be willing to do a bit of extra work this winter, and then figure out what needs to happen for them to actually come in and do that work, because that hasn't happened. So NHS staff in England have not received, oh, well, I mean, there's no point talking about this in resentful terms, but there are healthcare communities around the world which have really recognised and supported staff having gone through COVID. They've given them pay rises, they've given them other benefits which make their working lives a little bit easier during an incredibly stressful time. England hasn't done a jot, hasn't done anything at all. In fact, they've done the opposite. They've gone to the papers and have scapegoated staff. What needs to happen right now is that staff get incentivized to go to work, and they are not sort of hauled up or blamed in the papers for expecting to be paid a bit more to work overtime. I say this very frankly. I had a text from a friend last night. She's a consultant. She works in London. She works incredibly hard. She's had an incredibly traumatic couple of years. She was asked to come in at the weekend on an absolutely derisory hourly rate to look after some very, very unwell patients with COVID. And she said no, because quite frankly, people aren't willing to put themselves through it. And I don't think we can blame them for that, because NHS staff are workers. Now, there are things called locum caps in the NHS. They're one of the things that have destroyed NHS staffing over the last few years, because the long-term things haven't been put in place in terms of training enough staff. We don't have enough to fill the gaps. And the way the NHS copes with that is it pays people to work overtime, and they are called locums. Locums get scapegoated in the press constantly, but locums are what you need to plug gaps in the services isn't functioning. So locum caps is when you set a top level of money that you can pay a member of staff when they do an extra shift. It's normally pretty low, and it's normally not enough to entice people to do the work. And so there's gaps and patients suffer. And those locum caps need to be removed this winter, and there needs to be enough budget given to NHS trusts and other places and GP surgeries so that staff can be employed, because there's a lot of focus often on hospitals in this. And Emily will tell you she has to run a budget, she has to employ staff, she needs money as well to do that. So that's really, really important. And the social care crisis, which, like I say, is not really our remit, but it needs to be tackled immediately. Staff need to be found there. Again, staff need to be paid properly. Staff in social care aren't paid very well. If we want to get patients out of hospital and cared for well, we're going to have to find people to do it, and we're going to have to pay them properly and support them. The government, up until this point, have not shown a willingness to support staff or patients. And personally, as a doctor who worked within that system, as a doctor who now advocates for NHS staff and patients as a living, I put the great onus and responsibility on their head. A lot of these decisions to dismantle the NHS have been made willfully, on purpose, in order to privatise the service. We are now seeing patients dying. It's appalling. So coming away from this presentation, I don't like to sound like a doom mongerer. I know that most of the time I do, or I get angry online, but I'm angry because people are dying, and I'm angry because not enough people care, and I'm angry because the government aren't doing enough, and I'm angry because doctors commit suicide, and I'm angry because there are patients right now, right this second, lying on a floor, and they've called an ambulance and it hasn't turned up, and it's not good enough, not in the UK, not in 2021. So I would urge everybody who's on this call, and I really appreciate you being here, to please talk to your colleagues. If you're a journalist, please cover this. Please come to us. We can link you up with people within our network who can speak out about what's happening. And don't let this happen, because I wonder how many people are going to die this winter as a result of this, and it was preventable. So thank you ever so much. If anybody would like a copy of our briefing document, which has all of the statistics in it, just drop us an email on campaigns@everydoctor.org.uk, and we'll be delighted to send you a copy. We'll be telling our network, the MPs who have turned up today, because we really appreciate it. And we will also be letting them know, the MPs who would have liked to be here but have had another commitment. For those who haven't come and haven't engaged with us, we will be letting our network know that their MP is not standing up for them and not standing up for the NHS, because it's got to the point where we're in an absolute emergency and MPs need to be doing something to represent their constituents and safeguard their health. Thank you so much, guys. I'm going to say bye-bye now. Thank you so much for joining us today.